start off our conversation, the world is panicking with Mpox because I think we've all been scarred for life after COVID-19, and now everyone's worried about it, everyone's talking about it, and Mpox is the buzzword for the day. Can you explain to us briefly what exactly Mpox is?
Mpox was previously called monkeypox. It is a DNA virus. Now, there are two types of viruses, basically two broad categories, RNA viruses and DNA viruses. Mpox fits in as a DNA virus. It is called a orthopox virus, and that is the one that was found in the UK in 2022 and several other countries, and over 100 countries, where we had a number of countries getting Mpox in 2022. Now in the UK, there were 45 cases of Mpox clade 2B in July 2024. Now what we are dealing with and what people are talking now is quite a different condition. It's due to Mpox clade 1B. So that's a very important thing to remember.
Mpox is on the rise, and so is misinformation about it. We clarify things with Professor Suranjith Seneviratne. Stay tuned.
Some bonds give more returns. Get more security and more interest on your fixed deposits from Sri Lanka's largest finance company, LMDtv Finance.
The latest issue of LMD is available at lmdmall.lk as well as selected supermarkets and bookshops. You can also access the digital version on WhatsApp and our social media platforms.
Hello and welcome to LMDtv. The topic of conversation today is Mpox, and we're here with Professor Suranjith Seneviratne, who is the president of the Sri Lanka Medical and Dental Association in the UK. He's also a professor and consultant in clinical immunology, allergy, and immunogenetics at the Royal Free Hospital, University College London, and Health Services Laboratories, London, UK. Professor, it's lovely to have you on our show.
Thank you, Ruwandi. Thank you for the invitation.
To start off our conversation, the world is panicking with Mpox because I think we've all been scarred for life after COVID-19, and now everyone's worried about it, everyone's talking about it, and Mpox is the buzzword for the day. To give our audience a background to the topic, can you explain to us briefly what exactly Mpox is?
So Mpox was previously called monkeypox, and now they've abbreviated it to Mpox. And that's the term that we'll be using during this discussion. So it is a DNA virus. Now there are two types of viruses, basically two broad categories, RNA viruses and DNA viruses. So the RNA viruses, we know a lot about: HIV, influenza, SARS-CoV-2, the COVID that caused COVID. So those are the RNA viruses. And then you have the DNA viruses. And the Mpox fits in as a DNA virus. Now, it is what we call it is called a orthopox virus. So what it means is, by orthopox virus, is that the other viruses in that category is the smallpox virus, which we don't have now. It's not in the world. And then you have cowpox and vaccinia. So that is the orthopox viruses. Now, some people will get a bit confused because they have heard about chickenpox and wonder whether the chickenpox, the virus causing chickenpox, is also in this group. No, it is not. It is the chickenpox virus is a herpes virus, and it is not the orthopox virus, which the Mpox virus belongs to. So this has been in animals for a long period. 1958, it was found in monkeys. First condition, the human condition, occurred in 1970, and it has been causing infections, that's Mpox infections, in Africa, Central Africa and West Africa. So Central Africa, predominantly the Democratic Republic of Congo and the countries joining that. And in West Africa, you have been having another type of the virus, the same Mpox virus, but another type that has been circulating. Now in 2022, so if I classify the Mpox virus, there is clade 1 and there's clade 2. Clade 1 is the one that was circulating in, that is mainly in Central Africa. That's Democratic Republic of Congo and the adjoining country. Clade 2 is the one that is found in West Africa. And the importance of knowing that is because clade 2 viruses can be divided into A and B. Clade 1 is A and B. Clade 2 was less infective, caused less severe disease, and that is the one that was found in the UK in 2022 and several other countries, and over 100 countries, where we had a number of countries getting Mpox, was called monkeypox at the time, in 2022. But that was clade 2, 2B. It was less severe. It was mainly between men having sex with men, and it was sexual, that there was a close contact during sexual contact, and still that condition occurs around the world. So now in the UK, there were 45 cases of Mpox, clade 2B, in July 2024. Now, what we are dealing with and what people are talking now is quite a different condition. It's due to Mpox clade 1B. So that's a very important thing to remember, because the WHO came up with indicating that it is a global health emergency of international concern, and I'll tell you why they did that. So that was relating to not clade 2B, it was relating to clade 1B. So in September 2023, now if you take the Democratic Republic of Congo, it's in the center of Africa, you find that in September they found the condition in Eastern DRC, they found the condition changing a bit. That is, people were, due to sexual contact, they were getting the condition and then they were transmitting it, the people who got the condition, to children. And that is an important thing to remember. Children were getting affected by this condition. And when they tested, so this was September 2023. And then in January, it was investigated. And they found that it was mainly in the Democratic Republic of Congo, the truckers, when they were taking long distances and they were coming into sexual contact, they were transmitting it. And then children were getting it, because children, we have to remember, have not received the smallpox vaccine. And the smallpox vaccine used to give some protection against Mpox because it's in the same family, in the genus. So they were not getting the smallpox vaccine, children were getting it. And that is the number of cases that we are hearing about in the Democratic Republic of Congo. So far in this year, 2024, there have been close to about 14 to 15,000 cases in Africa, predominantly in Democratic Republic of Congo. Some cases are found in Burundi, that's just with the eastern border, some in Rwanda, some in Uganda, and a small number of cases in Kenya. But we are dealing with the clade 1B. It is not 2B, which we saw in 2022. Now, why do I stress this? Because there has been a bit of confusion and sort of mischief making, etc., by some people making small clips. because there was a clip saying, there are so many cases in Singapore, right? But that is relating to 2B, not to 1B that we are more concerned about at the moment. The WHO informed us about this global health emergency and it was relating to 1B, and that is the one that we should focus during this period of time. If I may add in another point leading up to that. So you had 1B, so WHO on the 14th of August mentioned that it was a global health emergency of international concern, and people would be wondering why did they come out with this term. The reason is once they put that designation, it reduces red tape and it enables funding, etc., to be released for getting vaccines, for surveillance, for diagnostics, etc. So it has to be a problem. It has to be something of that the WHO takes note, but it also is a regulatory sort of factor that helps things to move forward, and for vaccines and the other processes to move forward and people to focus on that condition. And that was why it was informed, the WHO came out on the 14th of August. Now, on the next day, there was a case in Sweden. That was a person from the Democratic Republic of Congo going to Sweden, taking the condition. That was 1B. Subsequently, in Pakistan, they said, but it was 2. It was the standard one, 2B. And then you had another case, again, a person coming from Africa to Thailand, and that was again 1B. So far, what is the current position is there are a number of cases in Central Africa, that is the Democratic Republic of Congo and Burundi, and there are these other cases, one in Sweden, one in Thailand, but it is not, we are referring to type 1B and not 2B, which was the one that was the problem in 2022. 2B is still circulating. As I said, in the UK, you had 45 cases of 2B, but that is predominantly among men who have sex with men, and the mortality or death rate is very low, less than 1%.
And Professor, like you said, since both are now happening simultaneously or so, is it only clinically diagnosed, or is there a way to get to know this, through symptoms, whether it's 1B or 2B?
No, it would be, so what we say is epidemiological pattern is important, right? So if you look at Africa, in the Democratic Republic of Congo, there are 3 sort of types that are circulating. That is 1A, 1B, and also 2. That's 2B. So, but 1B is the one that they're focusing. In West Africa and in Nigeria and in South Africa, it was 2B. And in the other parts of the world, you have 2B that is circulating. So the clinical features are very, very similar. So you have fever. Firstly, the incubation period is about, it can vary, but the incubation period can vary up to about 21 days, 5 to 21 days, right? So with the disease process coming on board, that is fever, a standard viral infection, fever, body aches and pains, sore throat, muscle pain, joint pain, headache, lymphadenopathy, where the lymph nodes are enlarged, standard infection that a person would, in symptoms that they would get if they have a viral infection. Then the rash comes out about 3 to 5 days after the fever, after the onset of fever. And the rash starts off and becomes a blister. It can break down, can get infected, a scab forms, etc. And that blister fluid is the one that is quite infective. And there has to be prolonged contact, but that is the one that is infective. So that blister fluid can be taken, or some other tissues can be taken, and you can do what is called a polymerase chain reaction to find out, to confirm the diagnosis. And secondly, to indicate and say what type is it, 2B or is it 1B. So looking at the feature alone, looking at the clinical features of fever, body aches and pain, sore throat, you cannot say if the infection is 2B or whether it is 1B.
And what would you say are the most significant risks with if we focus on 1B in terms of getting infected and also the risks of transmission?
Yes, so 1B, the pattern that is emerging now, it is as opposed to 2B, it is people who are having sexual contact, heterosexual contact has been high. And that was shown in a study that was done in the Democratic Republic of Congo in between September and April September last and April this year. And the important thing is prolonged contact with bodily fluids or infected material. So the thing is that it is not a casual contact. Seeing a person on the road, etc., is not going to transmit this condition. And the respiratory pathway is respiratory droplets. It's not airborne, it's respiratory droplets. So if you have prolonged close face-to-face contact with somebody and there's a respiratory droplet that goes and then can enter the other person's body, then it can occur. But it's this prolonged contact. One thing we have to remember with 1B is that about 3 healthcare workers in the study that was done in the DRC, about 3 healthcare workers also got the condition. So they can get it from bedding, fomites, etc. So that must be remembered, but that was a small proportion, and that was not seen, that was not common in 2B. 2B was predominantly, if you take the UK, 2B was predominantly sexual through male-to-male contact, and the mortality and the death was very, very low.
And Professor, would you say that certain segments of the population are more prone to like getting infected and of course, having a bigger impact? Like you said, there were more children getting infected.
More severe, exactly. So that's a very, very interesting and very important point to stress. So, we had smallpox in the world. It was got rid of 40 years ago, and smallpox vaccination has not been taking place for the past 40 years. So smallpox, the vaccine, when the person was vaccinated, they produce antibodies and cells, white cells, which protect the person from getting the infection or the infection being not too severe. Now, once that vaccination process stopped, you found that immunity wanes. Okay, so the immunity. So children who are born now don't get the smallpox vaccine, so they do not have any immunity to the sort of orthopox viruses. So that is one reason why the 1B, the initial transmission occurred among people who were in the camps, who were exposed sexually, or who were in contact, transactional sexual encounters with people who were truckers, long distance truckers. So they were getting the condition. But then because the 1B is more transmissible, it can be transmitted easier, they were getting it to other household contacts, etc., like children. And children, since they did not have protection, you were finding that the children were getting the infection. And the important thing to remember is, I told you the clinical manifestation, but a child less than 1 year, especially less than 1 year, a pregnant lady, that is important to remember, pregnancy, because the virus can go across the placenta, pregnancy, immunocompromised patients, that is where their immune system is not working well, especially cancer patient or other immune deficiency conditions like HIV or taking steroids for long periods of time. That is the group that we have to be focusing more, because if that group gets it, then the chances of there being severe manifestations is higher. We have to remember that we should not, this is not COVID. Mpox is not COVID. COVID was a different condition. It was airborne. It was very much more transmissible, etc. Mpox is not COVID, because otherwise people can panic and lose sight of what has to be done to bring this condition under control. There's an important point, however, which the world still has to learn. And I think this again will reinforce the fact that a condition anywhere is a risk to people all over the world. And that's very important, because Mpox has been in Africa, has been circulating in Africa, has been causing illnesses in Africa. The world became aware of, not aware, but took note of it when it came out of Africa, when it came to the developed world, UK, US, Germany, etc. Then they produced vaccines, and they had vaccination 2022. And then again, people became very complacent and forgot about the condition, whilst the condition was circulating in the Democratic Republic of Congo. And then what happened was, once they saw this happening in September last year, they found the number of cases going up and it being more transmissible. Still, nothing was done. It was only till it came to a crunch point in August, say September last year to August, not much was done. And people were crying out for in Africa, and the West was, and other countries were not taking too much notice. There were stockpiles of millions of doses of vaccines in the US, in the UK, in Germany. There was no sort of interest in getting those vaccines to the place that people needed it. It was Africa. So you found that the circulation occurred, the transmission occurs, and then when it went out of Africa and came to a place like Sweden, etc., everyone got panicked, and then there were so many sort of articles and so many speeches and etc. about the condition. Now again, the important thing is these vaccines, you have to have some perspective in it. You know, vaccines cost money. Each vaccine is $100. So you have to have WHO approval, and they should approve of that vaccine to enable donor agencies around the world to be able to get that, fund it, and send it to the places that are needed. And since 2022, certain countries have been stockpiling vaccines and keeping it for their own population. But things have dragged on and on and on. And because that approval was not there, you found that the donor agencies could not get the vaccines in time to Africa. So there has been some complacency allowing this number of cases to just expand out of the Democratic Republic of Congo to the adjoining countries. And then the issue is that there's an issue in infectious diseases that one does not get credit for an outbreak that is avoided. This is the paradox in infectious disease. If you prevent something, you don't get credit. So people seem to be waiting till the condition comes, affects the population, and then act on it. But this is the same thing that happened with COVID, and we are falling again into it with emerging illnesses where the action is very slow. People are stockpiling vaccines, etc., or other treatment options for their own population, and not really getting it to the heart of the problem where the circulation is occurring.
It's time to take a very short break, but we'll soon be back to talk more about Mpox.
What makes a truly awesome insurance company? Is it the skills to manage big numbers and big responsibilities? Well, that's definitely part of it. But there's more. It's the people. They're awesome. Super passionate about looking out for others and putting in their time for people's finances. It's not just the people. It's how we do things that's awesome. from being trendsetters of the industry to being connectors or inventors. It's about well-being and how we achieve it. Our teams hustle non-stop to meet the needs of the people. That's why we're on the rise. And it's not just about how we do things either. It's about how we improve things, helping our clients thrive in a world that's full of awesome goals to achieve. Making the maximum out of the minimum. But wait, there's more to it. There's one last thing that truly makes an insurance company awesome. It's that we care about our people and our customers. All of this combined, it's been a pretty awesome year. And we're excited for tomorrow.
Display your brand message on digital screens at prime locations. The largest digital advertising network in Sri Lanka. Emerging Media.
Welcome back to the show. We're in conversation with Professor Suranjith Seneviratne. Professor, you mentioned the mortality rate in 1B is significantly higher. Can you expand on this and, in comparison to COVID?
Yes. So if you look at the literature, the stated mortality rates were 3.5% in the West African strain and about 10% in the Central African strain. So that was that one was 10%, two was about 3%. However, when you put it into practice, the studies that have been done, when you look at more than 100 countries having 2B, the mortality has been less than 1%. It has been less than 1. This is 2B. When it comes to 1B, we have a study from DRC, the mortality in those who are hospitalized. So always you must remember, in those who are hospitalized, the mortality has been calculated at 1% in those who are hospitalized. So those who are not hospitalized, the mortality will be lower. So it is not that 10% that we are dealing with that was quoted before. It is about 1% in the study that had been done. It had been done from September to or October to April this year, October last year.
My next question to you is also regarding something that is being speculated and a lot of misinformation, disinformation. After the pandemic, after COVID, everyone was saying, is saying rather things that immunity has come down, the vaccine has caused this and that. Can I ask you to shed a professional opinion on this and whether immunity levels have indeed dropped, and is that why we are now seeing or hearing more of these illnesses, or whether it's another factor?
Okay, it's a good question, right? So viral infections will be coming, new viral infections will be coming and coming to the world as years go by. We have had the flu, the HIV, flu, COVID, etc., right? So the important thing was the world had a bad time during the COVID pandemic. We had lockdowns and all the problems with lockdowns, the mental health issues, the economic problems, etc. Vaccines came. Vaccines are not perfect when it came to adverse event. However, vaccines increased the immunity against the SARS-CoV-2 virus, and it contributed to bringing this pandemic under control. Now, when you give a vaccine, we always remember that you have an immune response after a time, a protein that is antibody, and a cell response. And that response will wane. It will wane because of vaccine responses. Sometimes it's not as good as the natural responses. That immune response will wane. Now, as I've mentioned a few times, the person, when it comes to COVID, the person who is at risk of that waning immunity are the immunosuppressed, the patient with cancers, the long-term ill patients with renal disease, etc. Their immunity is generally lower than others. And the vaccine or the disease immunity they get from either getting COVID or the vaccine is definitely going to deteriorate faster compared to the others. So currently, COVID, there are small peaks that are coming intermittently. We are lucky that the virus has not turned into a more nasty virus, because it could have always happened with Omicron, etc. coming. You found it was more transmissible, but the virus, the mortality or the disease severity was less, and we were better in controlling the condition because we had learned quite a lot of it. So you have people coming with COVID intermittently, etc. But now people are talking more about when can they go back to work, rather than being absolutely really worried by what complication. But we must always remember like any condition, there is a population that we have to protect. That is the immunosuppressed, the patient with cancer, the older, very much older patient, the immune system will anyway deteriorate after a certain age. That's the population we should note down. If there is a big increase in condition of the illnesses like COVID, then you would consider vaccinating that targeted group rather than just going and giving the 20-year-old person who is really healthy, who just can get access to a vaccine. Not that population. You will target the really needed group. So at the moment, even in the UK, you don't have, you don't have sort of big vaccination drives, etc. But if that is needed, then it is the target group, the older population, together with the person with cancers, etc., or their immune system not working, that you should target rather than everyone else scrambling to get the vaccine. Because immunity to a vaccine will wane. I mean, that is to be expected with anything. That is why we get certain vaccine, we get it twice, thrice, etc. So that can happen. And as shown nicely in Mpox, you find that those who are not getting the severe manifestation, but those who had some smallpox vaccine in the past, while the children, etc., don't have immunity. They don't have immunity against the orthopox viruses, and one of it is Mpox.
Talking about the rest of the population, like you said, in addition, or apart from the most vulnerable groups, in general, not just concerning Mpox, but in a world where you say viruses might get more common or more serious, how would you recommend people to increase immunity naturally?
Good question, and this is a question that is asked from any immunologist around the world. How do I increase? Is there a magic pill that I should take to increase my immunity? No, unfortunately, there's no magic pill, because there is this tendency, if I take this pill, my condition will disappear, or I will get a... There are many sort of health style measures which people can put in place. Proper diet. These may seem not very important, or not, the ones that will be on the headlines of a newspaper, but these are so important. Exercise, proper, sufficient amount of exercise, not being always sedentary, spending time in the sun, getting your vitamin D levels up, and the important thing about adequate sleep, because people are just taking that as a sort of a side issue, not having 7 to 8 hours of sleep. And the issue with that is, if you're immune, all the chemicals, toxic chemicals that are produced during a person's waking time is not taken out, how can that person's immune system operate properly? Then you have some certain other common sort of sensible things. If somebody washing hands is important. If you're going into an environment where lots of people have infections, we are in a mass at that time, could be important. So those are sensible things, but not forgetting the basic general health measures, because a lot of people think if they can take one sort of pill that will boost their immune system lifelong or throughout the year, but that is not so. Look after your health. Ensure that you have proper amounts of exercise. Your food should be not fast food. Your kitchen should not be outsourced to the closest fast food place where you only eat sort of processed food or food that is cooked by someone else where you don't have a control. So those are other measures to look after your immune system. It's a combination of measures and not only a pill. Getting your vitamin D levels is important, that you might have to take a tablet, but up to the suitable level. But the important thing is there are several factors, several things that the general public can take to ensure that their health is maintained.
Thank you, Professor. It was such an insightful conversation. But before we wind up, can I ask you for your message to the Sri Lankan population on how we should approach Mpox in a logical, healthy, as well as a sensible manner?
Thank you for asking this question, Ruwandi. So I think the government and the health authorities in Sri Lanka have produced circulars, etc., to be put in place, sent to hospitals, so that if there is a suspected person coming with from a country that has a high chance of the condition coming from, that they will be tested and they'll be isolated and the contacts will be traced. So that is in place. Now, what the general public should do is listen to people who sort of have some experience or sort of knowledge on the condition. When they give those health messages, listen to that, and then they will update the condition intermittently, say every month or every 2 weeks or every week, etc., and not get distracted by what generally circulates around in social media, right? Because it's very easy to take 10 wrong facts, combined with 2 correct facts. Mpox is caused by the Mpox virus. That is a correct fact. And then sort of confuse the population so that they go into a very, very sort of nervous situation and get extremely worried about it. But there are so many other conditions that we have to worry about, and so many other sort of things in the world that we have to focus on. We must not underplay it, but the health authorities will take the appropriate action. But at the same time, we must be considering the correct facts on the condition rather than considering everything that goes on social media.
We've been in conversation with Professor Suranjith Seneviratne, who is the president of the Sri Lanka Medical and Dental Association in the UK, and also a professor and consultant in clinical immunology, allergy, and immunogenetics at the Royal Free Hospital, University College London, and Health Services Laboratories, London, UK. Professor, it was an absolutely insightful conversation, and thank you very much for shining a light on truth and fact and taking away our confusions and, separating fact from fiction. It was lovely talking to you. Thank you very much.
Thank you.
And thank you to our viewers for joining us. Until next time, take care.
Don't forget to subscribe to our YouTube channel and follow us on Facebook, LinkedIn, Instagram, and X. Thank you for watching and stay safe.